Oh, I'm incredibly happy to see so many people here on LGBTQ plus STEM Day, where we're going to have an incredibly interesting talk by Justin Varney, the Director of Public Health of Birmingham City Council. He's going to talk about his experiences as an LGBTQ plus man, public health, and pandemics. And as an introduction, I'm going to give you to pass the baton, as it were, to my colleague Mike Cox, who's going to introduce Justin.
Thanks, Willem. I'm just going to do a quick introduction to LGBTQ plus STEM Day. It's very nice to see everybody here. Let me do the thing where we have to set up the slideshow. I hope everyone can see that. So, why do we need an LGBTQ plus STEM Day? So there is very little data about LGBTQ plus people in science, technology, engineering, maths, medicine careers. But this analysis in 2018 of over 4,000 respondents to a survey in the US identified that sexual minority STEM students are not retained at the same rate in STEM careers as heterosexual individuals, and that's by about 7%. So there's a leaky pipeline, and that's over 4 years. In the UK, the Royal Society of Chemistry and Institute of Physics and the Royal Astronomical Society last year published a report looking at LGBTQ plus people, and they it's one of the most detailed reports, and it's really worth looking at. It was focused on physical scientists. There hasn't been this kind of work done in life sciences in the same way. But respondents to their survey indicated that LGBTQ plus individuals had considered leaving their workplace because of direct discrimination or the climate at work, at a much greater rate than non-LGBTQ plus respondents. And this was worse for trans individuals. 18% had directly experienced harassment, 30% witnessed it. And this rose to 50% amongst trans and non-binary respondents. So remember, this is workplace discrimination and the climate. It's not on the way home, it's not the weekends, it's not at the evenings. This is workplace based. The number of LGBTQ plus individuals who are out to everyone at work, the proportion is relatively low. So about 60% aren't out. And this tells you something about the climate and the environment. People aren't comfortable enough to bring their whole selves to their workplace. And that affects your interaction with other people, and that affects how you feel about your work. The Royal Society of Chemistry identified these signifiers of an exclusionary environment amongst the people they surveyed. And these are 3 of those. So they identified that workplace policies and procedures don't necessarily adequately support employees who are not heterosexual or cisgender. The incorrect use of pronouns to address or refer to LGBTQ plus employees, and casual insensitive humour, even when it's not maliciously intended. So what can we do about this? So 3 recommendations from the RSC were to create a visibly welcoming community. Something I noticed, I joined the IMI at Birmingham last year, and something I noticed is that we actually have a good number of PhD and postgraduate students who are out, and to me that was instantly welcoming. That gave me confidence and motivation to do things like this within the IMI. So I just wanted to comment on that, and thank you very much to those individuals. We can also review and improve policies. and we can introduce and improve training. There are some simple changes, and use of pronouns is actually is one of these. It's very simply done. In Canvas, in your teaching, you can do it automatically in your profile. But this has a huge impact on those people who don't use the pronouns that you would assume they would. Life sciences societies are lagging behind physics and chemistry in their work in this area. The Microbiology Society, for example, included LGBTQ plus individuals in its EDI policy statement only as a footnote, literally a footnote in their statement. SFAM does a little better as the two key microbiology societies. The Royal Society of Chemistry is well ahead, and they have a really useful toolkit for employers, employees, allies. And that brings me on to one of the other ways we can address some of the discrepancies here and hope to retain LGBTQ plus students and staff in STEM careers is role models. And we have one with us today. So Justin Varney trained in Barts and London, and then with an MSc at Public Health in St George's. He became the National Strategic Advisor on Health and Work for PHE, and held that position from 2013 to 2019. Within that, he acted as technical advisory group member at WHO. He was the national lead for adult health and wellbeing, and he led the National Matrix Programme of Work on LGBT health inequalities, supporting government response to the National Survey on LGBT people in the UK. From 2019, with amazing timing, in February, he became Director of Public Health for Birmingham City Council. So I'm very pleased to welcome Justin to talk to us about himself, his career, and also, of course, a pandemic. Thank you very much.
Great, thanks, Mike. And it's always weird when you get those intros and you hear yourself. So I'm going to try and share my screen as well and get the slideshow up for you today. Let's get this going. So what I thought I'd do is I'll talk a little bit about myself, my career. I'll talk a bit about LGBT inequalities, because that's an area of public health I've worked on a lot. And then I'll touch at the end a bit about where we are on COVID and what has consumed my life for most of the last year. So as title of this, Rainbow Unicorns and Global Pandemics, which feels like the mashup that is my life at the moment. So just a little bit about me. So I came out when I was in my early teens, probably came out to the first other person when I was about 16. I started university, I was 17 when I went to uni. And I came out by a text message and a voice message to my parents on Valentine's Day. And I was very lucky because my parents' reaction was to send over a taxi the next day with a letter saying, "We love you, it's fine. And if you want your laundry done, please give it to the taxi driver and he'll bring it back to us." I came out my first year at university, and although I wasn't particularly involved in the kind of LGBT society at the university, and we didn't really have one at the medical school, I was more involved with LGBT politics and human rights outside of uni life, and was quite involved in what was then the Bromley by Bow Centre, which was an HIV voluntary organisation in East London, where I started volunteering as a receptionist. And this was back in the mid-1990s, and we were still seeing people dying very frequently. I got involved in GLAD, the Gay and Lesbian Association of Doctors and Dentists, and for over a decade I sat on the executive and co-chaired that organisation. I've been advisors to all sorts of different organisations. I helped co-found the LGBT Health Summit, and that was really off the back of doing work in the United States on LGBT health and being involved in the LGBT plus health summits there and the gay men's health summits over the years. And yeah, written and published all sorts of various things. But it gives you a kind of context in that over probably the last 20 odd years of my career, I've never been paid to do LGBT work. It's always been a kind of add-on, a bolt-on. It's something that I've taken with me throughout my career as an area of special interest, but I've never had a job which has been primarily within the LGBT community sector. But it's always been, as I said, part of what I've done. So for those of you that aren't familiar with public health is described as the kind of art and the science. It's that mashing up of evidence and politics. And some of the time I find myself feeling like I am a cultural attaché for the government and the health system. Other times I feel I'm very academic and embroiled in trying to interpret confidence intervals on research trials and what does that really mean. And trying to find ways to translate evidence into practice and into real terms about how you affect at scale populations. And I came into public health because I was originally training to be a GP. I had some health issues, some long-term health issues, which meant I was struggling to maintain my clinical practice in an acute A&E setting. So they said, well, why don't you go do public health? It's 9 to 5. You don't work weekends, which seems highly ironic now. But why don't you go and do that? Went and did a post in public health, absolutely loved it. And applied for a training number and then went on from there. And it allowed me to move from trying to change the world one person at a time to really trying to change the world at a population level. And, you know, this really is, Birmingham's a great example of that, because with a population of about 1.2 million, if we can significantly change the health of the people of Birmingham, we will change the national dial. It's big enough as a population that you do make a huge impact. But I did include this quote on this slide. You'll see throughout the slides, I love a good quote, and people always say things better than I do. And this is from an American journalist. But I think the bit that I thought was really important to highlight was actually this, you know, we always look for silver bullets. A lot of research is always trying to find the silver bullet, the medicine, the treatment, the vaccine, which is the answer. And actually the reality in public health is that there are no silver bullets. There is virtually never a single solution. You have to take a much more of a kind of, in this terms, buckshot or scattershot approach with multiple bullets going at the same time. And I think that was a really important reflection, actually, because it does describe a lot of my careers. I use probably a less violent analogy. I talk about throwing multiple pebbles into the water. And the aim of that is to create ripples, and those ripples intersect with each other and they become a wave, and the wave is what changes the shoreline. And the art of public health is timing your ripple to interact with someone else's ripple that will create a big enough wave that will truly change the shoreline. And that is very much what public health is about. And the pictures kind of just give you a sense of the two extremes of public health, and very much the two extremes of my career. At one end, supporting people around healthy eating, around basic sanitation, about healthy lifestyle behaviours, and at the other, outbreaks of infectious disease. And if I'd been speaking to you in the autumn of 2019, I would have said this is a tiny bit of my job, and that yes, I'd done desk stock exercises and I trained for pandemics, but you know, it hadn't happened yet, and you know, it would happen at some point. Of course, now it consumes about 95% of my my waking time, really, in terms of the emphasis. Public health has a series of quite structured roles. So there are public consultants in public health medicine like myself who are trained as doctors and then do specialist training in public health, and we're registered with the General Medical Council. As a medical specialty, public health is quite unusual in that you can train through the same higher specialist training to be a consultant in public health, so you lose the medicine bit, and then register on the UK Public Health Register. You can also register on the UK Public Health Register through portfolio submission. That involves around 60 boxes of paperwork. It's not an easy task, and a relatively small number of people that are able to get consultant status through that. There are also what are called public health specialist practitioners, so defined specialists in areas like epidemiology. That's through a portfolio submission, and they go on to the register in the defined specialist space. And then there are a lot of non-specialist roles as well. And to help kind of explain how all of public health joins together, so you have public health specialists who sit within local authority teams under directors of public health. They moved across from the NHS in 2013. We're responsible for commissioning a range of public health services, including NHS health checks, substance misuse, healthy child programme, but also providing health protection assurance and support to local NHS commissioning. And the budget for Birmingham is about 90 million. Which actually puts us about middle of the pack in terms of funding nationally. And over the last 5 years, we've lost about £15 million out of that budget in terms of central cuts. So it's a large amount of money when you look at it as a kind of quantum, but actually when you look at it per head of population, it doesn't go that far, considering some of these things are mandated in terms of commissioning. The NHS retains commissioning responsibility for what are called Section 7A public health services. So that includes immunisation, screening, sexual assault services and prison health. And then Public Health England is the national public health body. They provide support and advice. They have some specific laboratory functions in areas like Porton Down and Colindale. And they have some very specific health protection functions in areas like radiological exposure. So that kind of gives you just a sense of the way the system works together. So I'm now going to talk a bit about LGBT inequalities, because as this being an LGBT STEM day, these underpin some of why we experience life differently, but also some areas where I think it's interesting to highlight the research. But again, I think this quote just demonstrates actually how challenging at times this conversation can be, and that we still seem to be, as a society in large parts of the world, much more comfortable seeing two men with guns in their hands than we see two men holding hands. And actually how often we see still that seeing men with violent weapons on television is so much more acceptable than seeing them holding hands or kissing. And that we have come so far, but there is still so much further to go. For those of you that are EPI people, one of the interesting challenges has been actually there are very, very few statistical basis for how many LGBT and T people there are in the world, or in particular areas. And while I was at Public Health England, I was involved in getting a piece of work going on this, which pulled together evidence and gave a national summary for England. And it said between 2.5 and 5.89% of the population identify as lesbian, gay, bisexual, or other. And the 2.5 is those that self-identify as lesbian, gay, or bisexual. And then it goes up to 5.89 if you include those that identify with non-heterosexual identities in the other bracket. However, if you compare younger people with older people, younger adults are much more likely to identify with an LG or B self-identifier. And there was evidence from the GP survey that LGBT populations were more densely concentrated in urban settings. What was also interesting was there didn't seem to be a huge difference across ethnic groups or across socioeconomic demographics. But because we don't have the questions on sexual orientation or gender identity included in the census, there is still a paucity of data in terms of truly understanding the distribution of LGBT+ people across the UK. When it comes to trans, it's an even more difficult situation because there are virtually no population level surveys that ask around gender identity. So what we have is trans-specific research, which then has to be extrapolated out. And as you know, trans is an umbrella term. So we end up with proxies, such as the number of patients registered with a gender identity clinic, which are not giving the complete picture. So it is still a very challenging space when it comes to understanding trans prevalence. I pulled out in the next couple of slides just a couple of statistics from various different reports over the years around inequalities that affect the different components. What's interesting is when you look at gay and bisexual men and other men who have sex with men, they often combine into a single pool, and that's because in research, the language that you use is quite important. So we see studies around sexual health, for example, which focus on sexual behavior rather than sexual orientation or identity. And then we also see research which looks at relationship status as a proxy. And so looking at actually what the research is asking is quite important. It is very, very rare for us to see a sample that's big enough to separate out gay, bisexual, and other men who have sex with men into 3 different cohorts. There's some of the American studies that are big enough. There's some starting to come through from the ONS commitment after 2011 to include sexual orientation in population surveys, but the sample sizes tend to be small, so hence you get it pulled together. But as you can see from this, gay and bisexual men have much higher rates of depression, of suicidal ideation. Drug use patterns are really interesting when you look at particularly gay men's drug use. In essence, heterosexual men's drug use increases over their late teens into their mid-20s and then plummets. In comparison, gay men's drug use is a much more kind of upwards curve, and then it plateaus, and it doesn't come down again until much more into middle age. There is also a difference in the types of drugs being used. So gay and bisexual men are less likely to use heroin type drugs and injectables, and more likely to use what are classified in terms of space club and recreational drugs use. And yet we have a drug support system in terms of substance misuse clinics, which are based on heroin and opioid-based addictions. So there's a kind of structural inequality as well as an inequality in the pattern of use that then means you've just got a mismatch in terms of support. Gay and bisexual men remain the highest proportion of new HIV diagnosis, but we did see last year one of the biggest drops, and that I think is a strong reflection of the introduction of pre-exposure prophylaxis. And gay and bisexual men experience domestic violence at a similar rate to heterosexual women in terms of its incidence. And I think that's quite a powerful statistic when you think about actually how limited the support services are available to this group. Moving on to lesbian bisexual women, similar high rates of depression, high rates of suicidal thoughts. Recreational drug use in lesbian bisexual women is relatively low in comparison with heterosexual women, and both are much lower than gay men or heterosexual men. But in lesbian bisexual women, there is consistent evidence of significantly higher rates of alcohol dependence. Smoking rates are higher. That's also true for young gay people as well as young lesbian people, significantly higher than heterosexuals. And there is consistent and repeated evidence that lesbian bisexual women have issues accessing gendered cancer screening. And that continues to be an issue through multiple pieces of research over the years. It has improved slightly, but not majorly. One thing I would just highlight on this slide is the bias in the research base. So there is more research available on gay, bisexual men and other men who have sex with men than there is on lesbian, bisexual women. And that's often because what researchers have done is integrate into their research wider questions, but the primary funding and the primary focus is on HIV prevention. So we gathered a lot of intelligence around gay and bisexual men through the intervention of HIV research. Lesbian bisexual women have not benefited from this. So there is a significant gap. Much of the lesbian bisexual women's research is qualitative, relatively small scale. There are some exceptions. There's a very large lesbian bisexual women's breast cancer study out of America, but it is by far the exception rather than the rule. Whereas there are much larger studies for gay and bisexual men, primarily, as I said, funded through HIV research. In terms of bisexual women and men, very under-researched population. Again, very hard to get a sample size which is big enough in any of the research that's there. But what we do see from research with these communities is higher rates, significantly higher rates of suicide, suicidal ideation and suicidal attempts. There's one piece of research that on this that I found that's reasonable in terms of quality around poverty, but it is a very shocking one, and it highlights that bisexual women are twice as likely to live in poverty as their lesbian counterparts, and bisexual men are 50%, so half as likely in effect to live in poverty than gay men. So there's some really odd dimensions of financial inequality, but it's an area that very little research and investigation has gone into. Smoking rates are higher. And then this final statistics, which I think is quite shocking, but is replicated in multiple pieces of analysis across the world, is that bisexual women are much more likely to experience rape than lesbian women or their heterosexual counterparts. And again, we see this when the crime data is analysed, where sexual identity and orientation is questioned. This data just replicates repeatedly. But we do not see that kind of playing out in policy decisions or playing out in service provision. Where I said it was bad in terms of the evidence base for bisexual people, you can multiply that by a factor of 10 when it comes to research into trans people. Where we have research, it's predominantly around very skewed samples of populations. So, for example, there's some really interesting research which comes out of Brazil, but it is focused on trans women working in the sex industry. So it's a very skewed sample and not necessarily transferable in its findings. Where we have some UK research, it's predominantly grey literature. So the Trans Mental Health Survey, which was one of the largest surveys of trans people in the world, its time in 2018, found very, very high rates of suicidal ideation. The Stonewall research has demonstrated repeated discrimination, both in terms of hospitality and retail, but also in terms of healthcare. And when research does look at issues like smoking, or substance misuse, those are significantly higher in trans communities than in either the LGB or the cisgender comparators. But there are real challenges in getting funding for research in this space, and that has limited basically the evidence base on which we can draw. Touch a little bit about inequalities, but I think some of this was already covered in the opening comments. This is from a piece of work that I was involved in when I was on secondment to Business in the Community, the Prince of Wales's business charity, and looked at a very large sample of UK-based employees in the FTSE 500. And what that found was over 35% of younger adults in the workplace had hidden their sexual orientation or gender identity because of fear of discrimination. I think the one that probably shocked me most was 28% of LGBT plus chief executives or board members had explicitly been told to hide their sexual orientation at work. And I think one of the interesting things is that kind of some of what is reported is people's fear preventing them disclosing and being their authentic self, but to actually ask someone, have you explicitly been told? And I remember much earlier in my career being in a lift with a very senior member of the Department of Health, who was a kind of supportive comment, said, well, you realise that you'll never be Chief Medical Officer, you're far too gay. And it was one of those lift conversations that I kind of was like, rocked me a little bit. And then part of me went, well, I don't think I ever want to be Chief Medical Officer, but still, you know, just what was given as a piece of friendly advice, in inverted commas, actually could have been very, very detrimental. And it did, certainly for me, rock me a little bit. And I had, so, you know, did some reflection about how visible I was in this space and on these issues. The other one that I put into this slide, or there's much more data in that report, is the 12% of trans people who'd been attacked in the last year by someone they worked with or a customer, and that's physically attacked. This is a UK-based sample. You know, we have had legislation for a long time protecting people, but legislation isn't the only solution. We need that scattergun, the multiple pebbles, to be able to achieve change. So before I move finally on to the COVID section briefly, I just wanted to highlight some of the things that organizations can do, and those were alluded to in the opening comments around visibility, about education, the balancing between targeted and inclusive, and working with communities and developing and empowering communities. You know, I have no doubt that the funding that streams into the LGBT community for HIV prevention is drying up. And drying up very, very quickly. And so I think we will go through a period of further austerity. There is austerity already in the voluntary and community sector, but austerity for the LGBT community sector will become even tighter as that HIV prevention stream dries up further. But as individuals, we also need to be honest about some of the challenges. It's great to have visible leaders and allies. The language is really important. You're being visible and being counted. If you don't count me, I just don't count. So thinking about in your own work around how you capture demographics in research trials and studies is really important. Even if the sample is small, the fact that it's captured is helpful, because you could look at that data and look at it because it may show something. If it's not captured, you're never going to be able to look at it. So, you know, it's kind of, at least allow for the possibility. But I do think it's important to be honest about the risks. Being a visible LGBT person, particularly in leadership, is not without risk. We still have, unfortunately, a tabloid press, which is now particularly virtual. In this week of Anti-Bullying Week, you know, really important to just highlight, there are trolls out there who take pot shots, who still view LGBT people as being deviant, and will use horrific and horrible language to attack you in social media spaces. And that can be very hurtful, and we need to be aware and acknowledge that that is a real risk. So finally, I'm going to touch briefly on COVID. I'm sure for this audience, I don't need to talk about the biology of COVID and the coronavirus family, or its transmission, or the interventions we need to put in place to stop transmission. One of the challenges of COVID has always been that the interventions are relatively simple. Yeah, and actually it is much harder to get a population to adopt relatively simple interventions than it is to get them to take a pill or have a jab. Things that require people to make individual decisions on a repeated basis every day to reduce their risk are very, very hard to truly embed in a population at scale. And we've seen that consistently through the outbreak. Legislation is supportive, but it is not effective on its own. Enforcement, similarly, we have to have culture change, and that requires quite a different approach, which requires a lot of leadership, a lot of partnership, and a huge amount of engagement. And, you know, I think, you know, Dr. Tedros's quote here is a really powerful one, actually, about, you know, we don't use the pandemic word lightly. And it is often frustrating when you see COVID denial, particularly from people who frankly should know better. where people are going, well, let's have a bit of an intellectual bounce around with this, without really reflecting of the damage that that does and really thinking through what the ramifications are for individuals. And it probably annoys me most when I see academics using their academic titles and their position to question in areas of science in which they have no expertise, because the majority of the public see doctor and they don't understand the difference between a PhD and a medical doctor, and they certainly don't understand the difference between someone who has a PhD in linguistics and someone who has a PhD in virology. They just see Dr. So-and-so academic issuing their view on the science. And that does cost lives. People believe fake news, unfortunately. And we've seen that play out in people not going to hospital when they needed to, people not taking up testing, people putting themselves and people they love and care about at risk because they believed someone spouting off who frankly should have known better. But in terms of our response, there's a whole range of work around testing, case identification. Keep in mind this was a new virus variant that appeared in December. We just didn't have testing capability. And there've been some real stars, particularly actually Alan McNally's team and colleagues at the University of Birmingham lab have been really at the forefront of moving us at pace on this. Outbreak response, just in the last week, we've worked with over 400 schools in the city, providing bespoke advice to respond to outbreaks and clusters. It's a huge amount of effort. That what you do is pretty straightforward. There's a pretty nuts and bolts approach, but actually how you then work with people that aren't public health specialists to contain and respond to this. Risk reduction, as I've said to you, this is the big challenge. How do we get people into everyday habits that keep them safe? And how do we do that in a way that battles the fake news, the conspiracy theories, all of those angles? Because we know from the research that the one strongest factor for reducing mortality is public confidence. Public confidence in national government and local government is the one consistent factor that is most likely to reduce mortality. And yet, in these days of 24/7 media, it's very hard to develop that and ensure it. I touched briefly just on last two slides on the LGBT issues occurring during COVID. This quotes from work from the LGBT Foundation in Manchester. We were doing similar work in Birmingham, which is just being written up, but shows similar aspects. And I highlight it not to go through it in detail, but to emphasize that actually LGBT people's experience of COVID has been different. And there is growing evidence that in some areas this is a greater inequality or an enhanced experience of things like mental health. So the baseline was already higher rates of mental ill health, and so once COVID was added, that then amplified that inequality. There are some specific dimensions, particularly that LGBT people much more likely to live alone, much less likely to have a close social support network of family. And so the dependence on the public sector support, particularly for elderly LGBT people, is more pronounced, but also different dimensions that were unique to the LGBT community that we might not have thought through. So, for example, in my own engagement sessions with the community, people highlighted bereavement, and that where in normal times you could have physically gone to your parents when they were on their deathbed and had the conversation that you needed to have, in the COVID restrictions that wasn't possible. And actually trying to have this conversation to overcome perhaps years of discrimination within the family is not possible by telephone or Zoom. It's just not the same. So there were some real issues within the community with members who felt bereavement had been very difficult because the restrictions had prevented them from having what would have been a closure conversation. and similarly restrictions on funerals, etc. So there are some interesting dimensions of this, which I think we're only just starting to really understand. So finally, looking to the future, I mean, I think there is lots coming down the track. Vaccines undoubtedly do offer a light, but this train is 2 to 3 miles away. It's not going to arrive tomorrow, and it's going to be a massive effort to get the vaccines out. In the meantime, we will see pressure in the hospitals increase. We will be continuing to support people to try and make those everyday behavior change that reduce their risk. And, you know, I am very nervous about the festive season and what that will mean to case numbers and to deaths. In Birmingham to date, we've lost about 1,500 people. The bombing and the Blitz cost the city about 2,000 people. We're definitely heading in that direction now, and that would be a very sad legacy for COVID to have on the city. And then the final reflection I would have in this is that small box to the bottom around love. COVID has made all of us reflect on our relationships. It's made all of us reflect on what is important. And it's made all of us reflect on our own compassion for ourselves and for those around us. And I do hope that one of the positive legacies of this is that we will see a more compassionate future and a more compassionate environment, not just for LGBT people, but for the wider world as well. So I hope that's been helpful and interesting, and I'm happy to take any questions from the group.